Good morning. I'm going to update you on our phase 1 trial with a BRAF inhibitor called PLX4032. I'm here in representing the other co-investigators listed here. This was really very much a joint effort across 2 continents. This is a phase 1 trial with an oral drug called PLX4032. And there was 2 phases of this trial. There was an initial dose escalation phase where we were trying to find the highest safe dose of the drug, and also to get an idea of what kind of side effects that we could expect. And we studied the drug levels of the drug after patients took it. And then there's a second part of the trial, which I'm going to focus on, in which we took patients who had melanoma, all of whom had this mutation in BRAF, which I'll talk about, and then treated them all at the highest safe dose, which turned out to be 960 milligrams twice a day, again with this oral drug. I have to give you a little bit of background. We know that it's important how cells signal. They need to sample the outside environment to let them know whether or not they should be dividing. This is one of the pathways that is very seminal in a lot of cells and turns out to be very important in melanoma. There's a hormone that binds up here that starts this cascade through NRAS, RAF, MEK, ERK, and then that leads to cellular proliferation, or not, depending on what's appropriate for the cell. What we know about melanoma is that in about 50 to 60% of the melanomas, there's a mutation in this element here, which is BRAF. There's a V600E mutation, which results in BRAF being constitutively turned on. It's always turned on, always signaling through this pathway. This leads to abnormal cellular proliferation, and we think this is what drives the cancer. We talk about the melanoma cell being addicted to RAF. And so the idea was, what if we blocked RAF? That should turn this whole cascade off in melanoma. And so the Plexicon people developed a drug called PLX4032 that blocks RAF. This is actually a diagram of the parent compound, but it's very similar to the compound that we used. Blocks RAF, turns this pathway off, and this stops the abnormal cellular proliferation. Now there's a lot of preclinical data supporting this, which I'm not going to get into. But we brought this drug into patients to see if this would work in patients. And as I said, we initially did a dose escalation phase of the trial, trying to find the maximum tolerated dose, which we did, 960 milligrams twice daily by mouth. And so what I want to talk about this morning is this second cohort of patients who were all treated at this dose, all of whom had melanoma, all of whom had the mutation in BRAF. We have treated 31 patients so far. You can see men versus women, about twice as many men as women, as typical of metastatic melanoma. Median age, they all had a good performance status. Most of them had stage M1C, which means that they had metastatic disease to distant organs beyond the lungs, so liver, bone, other organs. So a very poor prognosis. And they had, and the bottom part shows that most of the patients had prior therapy. So they had failed 1, 2, and sometimes 3 different previous treatments. So I'm going to show, these are the response rates of the patients treated. As I said, we had 31 patients. I'm showing you 27 patients. There are 4 patients who have not yet been evaluated because they had just been too recently put on the study. So these are 27 patients. This is a waterfall plot which shows the maximum change in the tumor size. Bars that go up means that that patient's tumor got bigger. Bars that go down, their tumors got smaller. Each bar is a different patient. And you can see that of the 27 patients, 25 of them had tumor shrinkage, and 19 of them had tumor shrinkage that was more than 30%, which qualifies it as an official partial response by RECIST criteria. We had one complete response on these data. Actually, since we put the slide together, one of the partial responders has become a complete responder, so we actually have 2 CRs. The different colors indicate how extensive the metastatic disease was. The M1As are melanomas, are patients where the tumor has only spread to distant skin sites or lymph node sites. The M1Bs are lung, and the M1Cs are anywhere else. So 70% overall response rate, which is, to put it in context, chemotherapy is about 13 to 15%. That's where we've kind of been stuck at with conventional treatments. To show you what these responses look like, all the patients got a PET scan at pre-treatment and day 15 of treatment. So PET scan is looking at glucose uptake, and all of the dark spots are tumors that are taking up glucose. You have to really know how to read these because this is brain, which is normal. This is heart, which is normal, and down here is the bladder, where some of it gets excreted into the urine. So that's all normal, but you can see, for example, this patient had extensive liver and bony metastases, and after 15 days, the tumors are largely not taking up glucose anymore. Here is a bulky lymph node and lung metastases, mostly turned off. More liver, bone, turned off. And this one from Australia had widely metastatic disease. And you can see that after 15 days of drug, those tumors are metabolically quiet. More than metabolically quiet, they actually shrunk. And these are some examples of CT scans. And I want to show 2 examples only, but these are sites of disease that almost never respond to chemotherapy. This is a bony metastasis in the rib, which was painful. This is resolved after 2 cycles, which is 8 weeks. And in fact, it has recalcified, which I've never seen before. And this is massive liver metastases that are shrinking. So, in summary, we're treating with the V600E BRAF mutated melanomas at this dose of 960 milligrams twice daily. The treatment was well tolerated. I didn't have time to really show you all the toxicities, but there are 97% of the toxicities are grade 1 and 2, very minor. Usually rash, fatigue are the common ones. One thing of interest to us is that in 23% of the patients, they've developed a non-melanoma skin cancer called squamous cell cancer of the skin. This was very low grade, easily removed, and we're keeping a close eye on this, but it didn't have much of an impact on patients. The response rate, as I mentioned, 19 of 27 patients for a 70% response rate. I didn't have time to explain, but the rapid improvement in many patients. We had lots of patients who were on pain medicines, who were short of breath on oxygen, and had some remarkable improvements in their symptoms. And a phase 2 trial in U.S. and Australia is targeted to begin this month. And we have plans for a phase 3 randomized trial versus dacarbazine, which is expected to open either in December or January. Thank you.
Thank you, Dr. Chapman. The plan is that we take questions at the end, so if you can gather your thoughts regarding the questions. All I would add, and I'm not a melanoma specialist, but Dr. Chapman has given you a very calm presentation of data the likes of which has never been seen in melanoma. That waterfall plot, where all the lines are below the horizontal, with just about every chemotherapy drug, you could turn that upside down, and you get 1 bar, maybe 2 bars that would be below, and all the others would be on top. So this really is unheard of, and if it pans out, will be I was going to say, well, it's once in a decade, once in a generation. It is potentially remarkable data.